talk which T1 pulse should be used to study the preterm brain with a 3 Tesla scanner. Dr. Totora, the audience is yours.
Thank you. Good morning. Periventricular wet matter injuries and periventricular hemorrhage are major forms of brain lesion in preterm newborns. They may depend on same factors, such as the absence of brain vascular flow and regulation of preterm brain, the premature wet matter and consequence of these neurons' vulnerability to hypoxic ischemic injuries, and external factors such as infections. Periventricular wet matter injuries include a spectrum of cerebral injuries that ranges from the focal periventricular lesion that can appear as cystic or non-cystic lesion to diffuse myelination disturbances. But in this study, we focus our attention on the study in non-cystic lesion, which are recognized with MRI as bilateral symmetrical T1 hyperintense punctate lesions. The use of 3 Tesla MRI has been increasingly performed for study of preterm brain, primarily because of its potential to improve the spatial and temporal resolution. Therefore, at 3 Tesla, the signal intensity increases fourfold when compared to the 1.5 Tesla. But one of the main limitations of the 3 Tesla scanner is the loss of contrast of brain structures on T1 weighted sequences due to the increased T1 relaxation time. Therefore, the study objective was to compare different T1 weighted sequences at 3 Tesla scanner for study in order to find which is the most sensitive in identifying T1 hyperintense punctate lesions. The presence of periventricular leukomalacia was retrospectively analyzed in 200 preterm neonates studied at time correct age between 2010 and 2012. Finally, 36 preterm neonates were enrolled in the study. All MRI examinations were performed under medical controls, and exposure to the magnetic field and noise fall within the safety limits. In each patient, the number of T1 hyperintense punctate lesions was assessed in 4 different axial T1 weighted sequences: conventional spinnacle, an inversion recovery, an axial reformatic 3-dimensional fast field echo sequence, all with 3 mm of slice thickness, and the last one was an axial reformatic 3D fast field echo with 1 mm of slice thickness. The neuroradiologists independently analyzed all randomized sequences, and sequences were randomized to guarantee the blindness of investigators. In a second time, the same 2 readers analyzed the same randomized sequences in a consensus reading, which was considered the reference standard. For each sequence, they evaluate the number of T1 hyperintense punctate lesions, and they create 3 groups of sequences based on the overall number of lesions identified. Statistical analysis was performed using the ANOVA test to assess if there was a statistical difference between the overall number of lesions identified by the 4 T1 weighted sequences, an interclass correlation coefficient, and the blend-Antman plot to assess the reproducibility of the study. The highest number of T1 hyperintense punctate lesions was observed in 1 mm reformated 3D fast field echo sequence. The ANOVA test demonstrated there was a statistical difference between the 4 T1 weighted sequences, but only 1 mm fast field echo sequence resisted to the post-hoc analysis. In fact, there was no statistical differences between 3 mm T1 weighted sequences. Regarding results of inter-observer agreement analysis, there was a moderate to excellent agreement for all T1 weighted sequences, except for the inversion recovery, that shows the lowest interclass correlation coefficient and the highest standard deviation to the blend-Antman plot. The highest agreement was observed again for the 1 mm fast field echo sequence. These are 2 examples of preterm neonates studied with 3 Tesla scanner that show the different conspicuity of T1 hyperintense punctate lesions. In particular, they underline the difficulty in identifying these lesions on spinnacle and inversion recovery sequences. Our results demonstrated that the slice thickness and isotropic voxels are the main factors that determine the sensitivity of 3 Tesla MRI to detect T1 hyperintense punctate lesions. Although the difference was not significant, we observed an higher lesion detection by the 3 mm fast field echo sequence, and it's likely due to an higher signal-to-noise ratio of the fast field echo sequence. An additional issue favoring the use of the fast field echo sequences is the lower specific absorption rate observed when compared to other spin echo sequences. In conclusion, on the basis of this result, we promote at 3 Tesla the use of the 3D fast field echo weighted sequence for study of preterm newborns affected by the periventricular leukomalacia. Thank you for your attention.
Dr. Tortora, thank you for this very nice talk you gave. Are there any questions from the audience? Feel free. Just, if there's no question, I would step in as to methods and material. You kind of arbitrarily chose 3 groups as to the number of lesions. And I wonder how did you choose those groups? Why did you choose those groups? And could you tell us maybe something about the outcome? So what's the relevance of finding 2 or 20 lesions? Do you have any information on that?
We create 3 groups of sequence on the basis of the overall number of lesions identified, because we need the categorical data to the analysis of interclass correlation coefficient. I think that the distribution and the number of the punctate lesion could determine the outcome and of the development of the newborns. So in the literature, some studies demonstrated that the few number of T1 hyperintense punctate lesion can correlate with a better outcome of the newborns.
Thank you very much. I would just like to raise another question in addition. Since FFE is generically an echo signal generated from free induction decoy by means of a bipolar magnetic gradient, which is switching, do you think that the introduction of different flip angles may contribute to diagnostic validity and diagnostic accuracy of the sequences? And what do you think, what are your opinion of introduction of double inversion recovery pulses in the inversion recovery sequences?
The first question. Modifying the flip angle, we are modifying the weighting of the fast field echo sequence. For study of periventricular leukomalacia, we need a real T1 weighted sequence. So in the study, we didn't modify the parameters of the acquisition. But I think that we need an higher flip angle to have a T1 weighted sequence. Okay. Regarding the use of the double inversion recovery, our inversion recovery is a turbo inversion recovery. I think that also in the double inversion recovery, the signal of wet matter remains low. It could be interesting to find if it's allowed to increase the contrast between the punctate lesions and the surrounding wet matter. But we have, with use of inversion recovery, limits regarding the safety, because the inversion recoveries have an higher number of radio frequencies, and it increases the specific absorption rate. So I think it's better to use the fast field echo sequence.
Thank you very much once again for this very nice and interesting presentation. Now, our next speaker will be Dr. Czestovska.